Yeah, welcome to the webinar on DKA and management of diabetes mellitus after DKA on OP basis. So we have two excellent experienced speakers today. Dr. Hema Kumar is our pediatric intensivist, and you all know him very well. He has done his critical care from Rainbow Institute of Child at Hyderabad. And after DKA, to talk on office management of diabetes mellitus, we have Dr. Sirisha Kusuma. She's a pediatric endocrinologist at Rainbow Hospital, Hyderabad. She has done her post-graduation at Chandigarh, PGI Chandigarh, and after that, she has done her pediatric emergency medicine in Sick Kids, Canada, and she has done her pediatric endocrinology fellowship at Melbourne, Australia. She has vast experience on pediatric DKA and diabetes mellitus, management of diabetes mellitus also. Now, I hand over proceedings to Dr. Hema Kumar for the first thing, management of pediatric diabetic ketoacidosis. Hem, you have half an hour time. Okay, please be on time. Okay, start. Hem, let us start the proceedings. Okay.
Yeah. Thank you, Ramprasad sir. But I'm just a little bit disappointed because you have given me only half an hour time to speak on vast topic, that is pediatric diabetic ketoacidosis. But I will try to be very crispy. I will try to keep this things very simple and concise. So in next few minutes, we are going to discuss about pediatric management of pediatric diabetic ketoacidosis. Yeah, we all know it is a preventable complication, but serious complication of type 1 diabetes mellitus. It carries mortality of around 0.3 to 0.5% in developed countries. In developing countries, it constitutes about 10% mortality. We all know that it is just an interplay between insulin deficiency and excess of counter-regulatory hormones. So we all know about this diagnostic criteria to diagnose DKA. We should have hyperglycemia, that is blood glucose more than 200, and we should document metabolic acidosis, pH less than 7.3, bicarb less than 15, and we should be able to document ketosis also either in the blood or urine. And the DKA has been classified into mild, moderate, and severe DKA based on pH and bicarb. pH of less than 7.3, bicarb of less than 15 is classified under mild DKA, and pH of less than 7.2, bicarb of less than 10 is classified under moderate DKA. pH of less than 7.1 and bicarb of less than 5 has been classified under severe DKA. What are the goals of management of DKA? We have only 3 important goals, that is correction of dehydration with IV fluids and starting insulin to arrest ketogenesis and correction of any electrolyte imbalance during the therapy. These are the 3 important goals we have in management of pediatric DKA. Apart from this, we need to identify the precipitating cause and treat it, and we need to identify the complications during the therapy, and we need to address very rapidly. So coming to the fluid resuscitation of DKA. So why they are dehydrated, why they do have depletion of intravascular volume, what are the sources of volume loss? There are 3 main sources. There is from the kidney, from the gut, and from the lungs. Why they do lose tons of fluid from the kidney? Because we all know whenever blood glucose is elevated, and if it is beyond renal threshold, that is more than 180, glycosuria starts and it drags the fluid into the urine, and it results in osmotic diuresis, and child will have polyuria. The ketones produced in DKA will stimulate chemoreceptor trigger zone, and it causes a lot of vomiting. They lose a lot of fluid in the vomitus also. And the hyperventilation induced secondary to metabolic acidosis in DKA will cause a lot of insensible water loss. These are the three principal sources of fluid loss in DKA. So this fluid loss will result in hypovolemia. So because of hypovolemia, renal blood flow and GFR is reduced. So obviously no urine, no glucose is being excreted in the urine, and this results in elevation in the blood glucose further. So hyperglycemia worsens, and you see all effects of hyperosmolality because of elevated glucose in the blood, and because of intravascular volume depletion, acidosis will worsen. What happens once you reperfuse? Once you start giving fluids to them, then renal blood flow and GFR is established, and again glucosuria resumes, and it decreases hyperglycemia, and you see improvement in the acidosis. So fluids and correction of dehydration will itself will address the hyperglycemia. Not even without starting insulin, the blood glucose will decrease with fluid repletion. So initially, suppose if a patient comes to the ER and if child has blood glucose of 1000 and above, once you give venous bolus, the kidneys will kidneys will reperfused again, and now kidneys are able to dump glucose, and there is precipitous fall of blood glucose once kidneys are being reperfused. So after starting insulin, insulin does decrease glucose, but not at the same rate as reperfusion. Just you can see the curve here. So this is the effect of fluid bolus, and it goes, and the fluid will decrease the blood glucose level. This is the effect of insulin. So fluids will decrease more glucose than insulin. This we need to keep in our mind. That's why previous nowadays people are recommending against starting insulin and fluids together, because both insulin and fluids will drop glucose significantly. This will cause rapid shift in the osmolality, serum osmolality, and it will result in occurrence of cerebral edema. So what happens if a child is dehydrated? The hypovolemia will trigger a lot of counter-regulatory hormones like glucagon, growth hormone, and cortisol and epinephrine. This will activate hyperglycemia, and release of these counter-regulatory hormone will cause a lot of insulin resistance. So in hypovolemic phase, even if you give insulin, you need to give a lot of insulin to correct hyperglycemia in the phase of or in the context of hypovolemia. So it is very important to treat hypovolemia and then start insulin. In the context of hypovolemia, insulin will not act because of release of hypovolemia triggers release of these hormones. Once you dehydrate, you see decline in the counter-regulatory hormone, and it augments the insulin sensitivity. So without fluid depletion, we are not supposed to start insulin, because hypovolemia will cause a lot of insulin resistance. So what are our objects of fluids? Like in other types of shock, like in septic shock, here our goal of fluid resuscitation is to restore organ perfusion, not to restore euvolemia. So once organ are perfused, that is enough. That is the endpoint for our fluid resuscitation. So if they are reperfused, it enhances the renal glucose clearance, and it lessens the hyperglycemia. And once hypovolemia is corrected, there is decline in the counter-regulatory hormones, and again correction of hypovolemia will augment insulin sensitivity. Having said that, the beneficial role of fluids are not without any side effects. The overzealous fluid administration will cause rapid osmolar shifts by precipitously by causing precipitous fall in the blood glucose, and they can result in the case of cerebral edema. And the fluid uses osmotic diuresis. Because of this osmotic diuresis, child will develop hyperkalemia, also hypokalemia, hypophosphatemia. And over-the-jealous administration of fluids will result in fluid overload, and it results in both pulmonary and cerebral edema. The challenges in fluid therapy in DKA are, number one, the clinical signs of dehydration are not apparent because the intravascular volume is preserved until into the late stages. Because if you see the hyperglycemia, that is elevated blood glucose causes hyperosmolality in the blood vessel, and it drags the fluid from the cell. So it is apparently the intracellular dehydration rather than depletion of intravascular volume. The intravascular volume is preserved until late phases of dehydration because it is predominantly intracellular or interstitial dehydration rather than intravascular volume depletion. And second thing is hyperventilation induced by metabolic acidosis will cause CO2 washout. This hypocarbia will result in vasoconstriction, peripheral vasoconstriction, and peripheries become cool. That might mimic as a sign of severe dehydration. So it is very difficult to assess the severity of dehydration because signs of dehydration, clinical signs of dehydration are not apparent, particularly in DKA. So what are the principles of fluid therapy? What is the amount of fluid we should give? What are the types of fluid we should give? At what rate we should infuse? What is the ideal point of time to add dextrose? What are the complications associated with the fluid therapy? The three components of fluid resuscitation. One is as any with any type of correction of dehydration, we need to give bolus, we need to calculate deficit fluid, and we need to give them maintenance fluids as well. Then coming to the first bolus, the indication of bolus in a DKA is presence of hemodynamic instability. If you see signs of poor perfusion with or without hypotension, that is the indication to start bolus. Remember, shock is very rare in setting of DKA setting. If child has hemodynamic instability with DKA, then suspect severe fluid deficits and underlying sepsis. So if child presents with complete shock, then we administer fluid at 10 to 20 ml per kilo over 30 to 60 minutes. If child presents with hypotensive shock, we need to resuscitate them as per pulse protocol. Remember, this is a very, very important point. Bolus need more than 20 ml per kilo is extremely uncommon. So if you have to give bolus of more than 20 ml per kilo, think twice and thrice before giving second bolus of 20 ml per kilo. Up to 10 to 20 ml per kilo bolus is okay, but if you are going beyond 20 ml per kilo, think twice before giving. How to estimate the fluid deficit? As I said, the estimation of fluid deficit is very, very subjective. Some clinicians will come and say this child has 6% of dehydration, this child has 8% of dehydration. For some other person, it might be 10% dehydration. Traditionally, it has been calculated as any child with severe DKA, it was calculated like 10 to 15% of the fluid estimate, which is in fact a overestimation. This overestimation of fluids will result in cerebral edema, as all we know. But nowadays, the recent data has reduced this range to assumed deficit of 6.5 to 8.5% dehydration. So, by estimating deficits in a child with DKA, please calculate according to this 6.5 to 8.5% of the deficit. So, include in your fluid calculation the deficit of 6.5 to 8.5%, that equivalent to 65 to 85 ml per kilo, which is safe range of estimation fluid deficit. Always calculate lower fluid deficits, that is 6.5 or 5% in malnourished children, because they will be at risk of hypoglycemia and dyselectrolytemia because of excess amount of fluid administration. So, as we all know, calculation of the maintenance fluid is as per Hawley-Sigar formula based upon their weight. So, previous guidelines suggest reduction of the fluid bolus from the calculated fluid, but nowadays with conservative approach of the fluid estimation of the fluid deficit, no need to deduct fluid bolus from the fluid to be administered. Just calculation of the deficit and maintenance volume is sufficient. And but deduct boluses if you have to give more than 20 ml per kilo from the fluid calculated. So boluses above 20 ml per kilo, deduct them, but boluses below 20 ml per kilo, no need to be deducted from calculated fluid. So what is the rate and type of fluids that should be given in DKA? But different DKA protocols has used different fluid administration rates and different fluid types, because all this confusion is because previously it was thought that faster rates of fluid administration and use of hypotonic fluids in DKA is associated with cerebral injury and cerebral edema. Hence, there is a lot of debate about rate and type of fluids. This is a very interesting paper by this is a Precautions fluid trial that is published in Museum. So they compared fast rehydration rate with slow rehydration. In the intervention group, they had rehydrated the children very fast. They had given 20 ml per kilo of fluid bolus, and they assumed deficit fluid deficit was 10%. This fluid deficit was replaced with off normal saline or normal saline. Half of the deficit is replaced in first 24 hours and the rest in the next 24 hours. That is, total duration of correction would be around 36 hours plus maintenance fluid, and they continued insulin at 0.1 unit per kilo per hour. And this intervention group is compared with slow rehydration group, which has received fluid bolus of 10 per kilo of fluid bolus only, and they assumed fluid deficit of 5%. They resuscitated more conservatively, and this deficit is replaced, as in intervention group, this deficit is replaced with half normal saline or normal saline over 48 hours instead of 36 hours. Basically, it is the fluid resuscitation is spaced over 48 hours in comparison group, whereas in intervention group, the fluid resuscitation is spaced over 36 hours. The primary outcome they measured is the decay in the neurological status and clinically apparent brain injury is the secondary outcome, with other neurocognitive outcomes. The author's conclusion is neither the rate of administration nor the sodium chloride content of the intravenous fluid significantly influences neurological outcomes in children with decay. So what is the ideal rate of correction? Slow and even correction is always preferred, and even correction over 36 to 48 hours is always safe. The rate of correction is determined by initial blood glucose levels, initial serum osmolality, sodium levels, initial pH, and presence of acute kidney injury and Glasgow Coma scales. Slow correction over 48 hours is safe in resource limited settings where monitoring facilities are very less. Always it is recommended to correct dehydration over 48 hours. If you see high blood glucose that is above 500 at the time of admission, the slow correction over 48 hours is safe. If child presented with GCS of a low GCS at time of admission, then you need slow correction of dehydration over 48 hours. Particularly in malnourished children, always slow correction is preferred because they are at risk of developing hypoglycemia and dyselectrolytemia. So slow correction is recommended in all these 4 settings. What are the type of fluids that are recommended in DKA? Chloride liberal fluids and chloride restrictive fluids have been used in management of DKA. Chloride liberal being normal saline and chloride restrictive being vinegar lactate or plasmolite. And the optimal tonicity of the fluid, which is recommended, that is normal saline or half normal saline. So normal saline is the traditional fluid of choice, and it has been used for volume resuscitation and deficit replacement. The problem with using normal saline for resuscitation in DKA is normal saline is associated with increased risk of AKA because of high chloride content. Because normal saline contains 154 milliequivalent per liter of chloride. So this high chloride content is associated with the risk of acute kidney injury, and it can result in hyperchloremic acidosis. Hence, there is a trend towards uses of balanced slides, particularly plasma light in the management of DKA, because balanced slides are associated with reduced risk of injury and less risk of hyperchloremic metabolic acidosis. So this is the particular paper from PJ Chandigarh, which compared saline with plasma light, and the children are randomized into two groups. One group has received plasma light, another group has received normal saline, and they found the incidence of AKI or time to resolution of DKA is similar in both groups. There was no significant difference in with the both groups in terms of acute kidney injury or time to resolution of DKA. So until further studies are needed to recommend use of balanced exercise like plasma light in DKA. Until then, the current guidelines recommends normal saline for both volume resuscitation and replacement. What is the tonicity of the fluid we should use? That is there any necessity to switch over to half normal saline? So particularly, as I mentioned, the prolonged usage of normal saline is associated with significant risk of AKA and hyperchloremic metabolic acidosis. So it is always better to switch over to half normal saline after 4 to 6 hours of resuscitation. Particularly in resource limited settings where half normal saline is not be available, then NS is the choice of fluid. When to add dextrose, as I said, the rehydration will reserve hyperglycemia partially. So with subsequent fluid correction and subsequent starting of insulin will cause glucose at the rate of 50 to 70 mg per deciliter. Precipitous drop in glucose, that is more than 100 mg per deciliter, it should be avoided because it can result in rapid osmolar shift and results in occurrence of cerebral edema. So what are the indications? What is the ideal time to add dextrose into the fluid regimen? That is, whenever the blood glucose drops to 250 to 300 mg per deciliter, that is the time where you add dextrose. And with rapid fall of glucose, if you see rapid fall of glucose, that is more than 100 mg per deciliter fall of glucose, then addition of dextrose is recommended. Even in malnourished children, even at blood glucose levels of 300 to 350 mg per deciliter, addition of dextrose is recommended in the fluid regimen. So suppose if blood glucose is declining very rapidly in the face of non-improvement of acidosis, you need to hike up the dextrose concentration in the fluid rather than stopping insulin. So if acidosis is not resolved and blood glucose is falling rapidly, then the dextrose concentration in the fluid has to be adjusted rather than to stop insulin, because insulin is required to arrest ketogenesis. So these two bags protocol is proposed to facilitate easy adjustments in dextrose concentration of the fluid. Here, patient is connected to the two bags. One bag is one bag containing saline and electrolytes. Other bag containing 10% dextrose along with saline and electrolytes, and insulin will be running at 0.1 units per kilo per hour. Based upon patient glucose values, then you adjust rates from each bag, from saline bag and glucose bag. Suppose if patient blood glucose is more than 350, then no fluid is being administered from 10% dextrose, or the 100% of the total fluid rate is from saline bag. If glucose falls to 300 to 350, then 75% of the fluid rate is from the saline bag, whereas 25% of the total fluid rate will be from glucose bag. That constitutes around 2. And then you will be giving 2.5% dextrose in the fluid. If blood glucose falls between 250 to 300, then you adjust the rate, like 50% from the saline bag and 50% of the 10% dextrose bag. So this will allow you to adjust glucose concentration in the fluid very smoothly, and it will reduce the requirement of the change of the fluids, frequent change of the fluids. So this is about the fluid resuscitation in the DKA. And coming to the insulin therapy, insulin is required in DKA to arrest the ketoacidosis. So previous guidelines recommends the usage of insulin bolus. Insulin bolus is absolutely unnecessary because insulin bolus will cause precipitous drop in blood glucose and occurrence of cerebral edema. Hence, insulin bolus is no longer recommended. Even if you look into the pharmacokinetics of the insulin, the half-life of insulin is 3 to 5 minutes. So even if you start infusion at 0.1 unit per kilo per hour, within 15 to 20 minutes, you can achieve steady state concentration in the plasma. So insulin bolus, previous guidelines recommended insulin bolus to achieve steady state levels in the plasma rapidly. So no need to give bolus to achieve rapid steady state in the plasma, because insulin life is so short, that is 3 to 5 minutes. Even after starting 15 to 20 minutes, then you can achieve good plasma concentration of the insulin. So at what dose we should give insulin? There is a paper from Chandigarh, that is which has compared efficacy and safety of low dose insulin against standard dose insulin in children with DKA. So almost it is a prospective open label RCT. They compared 50 children are randomized into two groups. One group has received low dose, another group has received standard dose. Low dose group has received insulin of 0.05 units per kilo per hour, even at the beginning phase. And standard dose group has received 0.1 unit per kilo per hour of insulin. And the outcomes measured are, the primary outcome measured is the rate of increase of blood glucose level, and secondary outcome being resolution of acidosis. A conclusion is being low dose is non-inferior to standard dose with respect to rate of blood glucose decrease and resolution of acidosis. So there is no significant difference with respect to rate of blood glucose decline and resolution of acidosis if you use either low dose or standard dose. Low dose in the sense 0.05 units per kilo per hour. So which one to follow? Either 0.05 unit per kilo or 0.1 unit per kilo. Some pediatric centers still use 0.05 unit per kilo per hour, but remember there was no evidence that suggests higher dose like 0.1 unit per kilo per hour is harmful. But particularly in resource limited settings, it is always better to start with low dose of insulin, where we come across children with malnourishment, because malnourished children will have poor potassium stores and they are at risk of hypoglycemia. In those children, if you start insulin at standard dose like 0.1 unit per kilo per hour, they might be at risk of hypoglycemia with hypokalemia. And in patients with high risk of cerebral edema, suppose if we are seeing children at the delayed presentation with the prolonged acidosis, then also they are at risk of cerebral edema. So it is better to start with low dose of insulin like 0.05 unit per kilo per hour. These are the three indications to start low dose. One is in resource limited settings and malnourished children, and in patients with high risk of cerebral edema, then always it is better to start with low dose of insulin. So what are the precautions we need to take before starting insulin? Insulin can be mixed with NS or half NS. It should be administered through syringe infusion pump to control the rate of administration, and it should be administered through separate IV line. It should not mixed with IV fluids, and it should be concentrated as much as possible. So ideal concentration is like a mixed 50 units of insulin with 50 ml of half NS or NS, that comes to the strength of 1 unit per ml of infusate. So this is the ideal concentration of the insulin we should prepare, and this is important to remember that we should be flush it through the tubing before starting the infusion, because insulin tends to bind tubings and syringes. It is always better to flush through the tubing before starting insulin. So you have started insulin, but you have not seen any response, that is failure to achieve desired rate of the fall of glucose, then always check the patents of AVIR cannula and check insulin preparation and drug delivery of insulin. So drug delivery. So these are the 95% of the cause of non-response to the insulin is improperly prepared insulin. So always better to check patents of AVIR cannula, preparation and delivery, and then hike insulin if you after optimizing all these two conditions. So which route is preferable? Even in resource limited settings where you have limited facilities to monitor closely, then subcutaneous insulin is attractive alternative in mild to moderate DKA. So subcutaneous form is, that is, we need to use rapid acting insulin. Start with 0.2 units per kilo insulin, followed by 0.1 to 0.2 units per kilo every 3 hours until blood glucose drops to 250, and then dose is reduced every 1 to 2 hours until DKA resolution. But there is no strong evidence for subcutaneous administration of insulin in severe DKA. In mild to moderate DKA, in resource limited settings, you can give subcutaneous insulin with equal efficacy compared to intravenous insulin. So suppose, so just we take one example, a 20 kilo child with severe DKA as presented to us. Then first 0 hour we give, if we see any signs of shock, if it is compensated, we give 10 ml per kilo fluid bolus. If it's hypotensive shock, we give 20 ml per kilo over 1 hour. After 1 hour, then we calculate fluid deficit. 20 kilo child, the deficit is 6.5 to 8.5% of the body weight. We take 70% of the body, that is 7.7% of the body weight. So 70 into 20, it comes around 1400 ml, and plus maintenance fluid. So as we are giving over 48 hours, the rate of correction, as we have chosen rate of correction over 48 hours, the maintenance fluid we need to calculate for 48 hours. It turns to around 3 liters. So we need to give over 48 hours. So fluid deficit plus maintenance level divided by 48 equals to 92 ml per hour. So the 1 hour after fluid resuscitation, usually we start insulin at 0.05 mg per kilo per hour, and after 6 hours, if blood glucose drops to 250 mg per deciliter, then add dextrose, and after 12 to 24 hours, if you achieve endpoint of DKA, then switch to subcutaneous insulin. So if you don't have time to calculate all these cumbersome calculations, then just start with 1.5 to 2 times the maintenance. So you need not worry about 6.5 and all these calculations. Just keeping all calculations aside, just you start with 1.5 to 2 times the maintenance of the IV fluid. So how to counteract the electrolyte imbalance during therapy? So most common electrolyte imbalance we see is hypokalemia. This hypokalemia occurs secondary to osmotic diuresis and with insulin therapy, because insulin will cause transcellular shift of potassium into potassium. So potassium moves into the cell and causing hypokalemia. So both hypokalemia is treatment related, therapy related complication. It occurs secondary to some osmotic diuresis. So malnutrition children will have significant fall of potassium. So it is very important to monitor them with close monitoring with ECG and serial potassium levels is needed. So our target potassium would be somewhere around 4 to 5 milliequivalents per liter. So after admission, if potassium value is 3.5, less than 3.5, give potassium correction, and you can delay insulin administration if potassium levels are very severely low. And if potassium levels are 3.5 to 5, then add maintenance potassium at 40 milliequivalents per liter after ensuring adequate urine output. If potassium levels are more than 5, then delay potassium until 5. So phosphate, this is another electrolyte. They are more prone for phosphatemia because after starting insulin, will utilize all phosphate stores in the body. So, but routine supplementation of phosphate is not needed. Replacement is only needed if child is having associated cardiac dysfunction, respiratory depression, muscle weakness, and if serum phosphate levels go below 1 mg per deciliter, then only phosphate supplementation is indicated. So you can supplement phosphate in form of two salts, potassium phosphate or acetate. Bicarbonate. So it is having low bicarbonate, severe metabolic acidosis. Why can't we give bicarbonate? Routine supplementation is not indicated. In fact, giving bicarbonate in children with DKA is more harmful because it is increases the significant risk of cerebral edema. So the indication of bicarbonate in management of DKA is only in severe acidosis where the pH is less than 6.9 associated myocardial dysfunction. And if you see any life-threatening hyperkalemia secondary to acidosis, then only bicarbonate supplementation is indicated. How to monitor? So we need to give, ideally, we need to do blood gas and serum electrolytes every 4th hourly, and every monitoring of glucose is needed, and we need to check vitals every hourly, and continuous ECG monitoring is needed to check for rhythm disturbance secondary to hypokalemia, and we need to monitor neurological status like GCS and size hourly. What to expect? So we need to blood glucose. We need to ensure blood glucose fall of 50 to 100 mg per deciliter per hour, and pH increases by 0.03 every hour, and closing anion gap. So usually DKA is associated with the high anion gap. We need to monitor anion gap regularly, serially, and we need in the therapy. Closing anion gap indicates resolution of DKA. So anion gap of 14 or less than 14, it indicates resolution of DKA. And this is very important. Serum sodium should increase by 1.6 milliequivalent per liter for every 100 mg per deciliter fall of glucose. This is very, very, very important to monitor the serum sodium level. The serum sodium should rise with declining of glucose, and we need to ensure the least variability in corrected sodium, and we need to avoid rapid osmolar shifts. What are the endpoints of DKA therapy? Remember, resolution of DKA doesn't mean resolution of hyperglycemia. So it is the endpoints of therapy is normal sodium with good oral tolerance, and resolution of acidosis is that is pH more than 7.3 and bicarb more than 15, and closing of anion gap. So these are the endpoints of DKA. Once we achieve endpoints of DKA, then stop IV fluids, allow oral fluids, give 1 shot of subcutaneous insulin. After half an hour, stop IV insulin. So this is the very important complication during therapy of DKA, that is cerebral edema. The incidence is very less, although it is less than 1%, but it is associated with high mortality. So the typical timing of cerebral edema occurrence is it is seen after 2 to 24 hours after starting therapy, and pathogenesis of which is unknown. The cerebral hypoperfusion secondary to hypovolemia and dehydration is implicated in the pathogenesis. And second possible theory is osmotic disequilibrium caused by overzealous fluids and insulin bolus and alkali therapy, that is giving bicarb, and hyponatremia at the time of admission, that is failure to raise serum sodium 1.6 milliequivalent per liter for every 100 mg per deciliter. Fall of glucose is a subtle sign to indicate cerebral edema. So we need to avoid all these three things, right? Like overzealous fluids need to be avoided, and insulin bolus should be avoided, and all therapy should be refrained. So risk factors for cerebral edema: younger age, new onset diabetes, and severe dehydration for prolonged period. That is typically late presenter. Children who present to us late presentation will carry high risk for developing cerebral edema and severe acidosis at admission, and low PaCO2 at admission, and high urine nitrogen at admission. These are the risks for developing cerebral edema. Diagnosis: is major criteria and minor criteria. Clinical manifestations include from mild headache to coma. So it is the two signs important to appreciate, that is inappropriate bradycardia and hypertension. Hypertension despite dehydration are important signs to observe, and most common subtle signs are persistent alter sensorium despite improvement in acidosis and hyperglycemia is subtle sign to identify cerebral edema, to suspect cerebral edema, and fail to release serum sodium follow glucose, another sign of cerebral edema. So treatment of cerebral edema includes restriction of fluids and neuroprotective measures and osmotic therapy. Here the mantle is preferred over 3% NaCl and osmotic present. Thank you very much. Sir, should I hand over to Sirisha Kusuma ma'am?
Can you see my screen?
Yes, ma'am.
Okay. Full screen, right?
Yes, ma'am.
A very good evening, everyone, and thank you for attending on a Saturday night so late. And after the wonderful talk by Dr. Hema on how to manage an acutely presenting child in diabetic ketoacidosis, most of the times you take a breath of relief once the child comes out of the DKA. And however, many registrars and DNPs and young pediatricians have a little bit of confusion when it comes to how to go about the insulin therapy and further management, because many times the clear-cut guidelines are not easily available. So let us see how to go about it after DKA resolution. So like Dr. Hema already mentioned, when we are going to decide to shift to subcutaneous insulin. So basically, the resolution of ketoacidosis is the end point for your IV insulin therapy. So when there is a resolution of ketoacidosis, your bicarbonate is more than equal to 15, and child is active, alert, and tolerating orally at least clear liquids, that is the time to shift to subcutaneous insulin. And it makes sense to coordinate so that your shift is correlated with the meal time. It can be breakfast, lunch, or dinner. Before deciding to change the child into subcutaneous insulin, you need to decide what types of insulin you're going to use in a long run and what kind of an insulin regime that you're going to use, because there are so many different varieties of insulin available in the market, and there are different kind of regimes that we follow in different kind of children based on their sometimes based on their financial situation, sometimes based on their family situation, etc., etc. So let us first look at the types of insulins that are available before we decide what kind of insulin that we're going to put the child on. So this is a chart for insulin and its action profiles. If you see that this is a fast-acting insulin, we have 3 varieties available: Novorapid, Humalog, and Apidra, the trade names. Aspart, Lispro, Glulicin are the actual medicine names. So they start working within 20 minutes. They reach peak in 1 to 2 hours. They are out of the system by about 4 to 5 hours. The another insulin, short-acting insulin or regular insulin, the commonest example is your Actrapid. It starts within half an hour to 1 hour, reaches peak in about a couple of hours, and stays in the system for 6 to 8 hours. So these 2 insulins can be used as a pre-meal bolus insulins. Now we have a little longer acting insulin, which is your NPH. So it reaches the system in a couple of hours and reaches peak in about 6 to 8 hours. It's important to remember this peak for reasons that we're going to see later, and the action kind of stays for 12 to 20 hours. And now we have our long-acting insulins, Glargine and Detimir, which are available as Lantus and Levemir. And you can add a Degludec also, which is Tresiba. So there are 3 long-acting insulins available, which have pretty much flat profile of action up to 24, even longer than that. So coming to the onset of action, I would like you to know a little bit about onset of action, why we are going to see. When you come to pre-meal insulins, the rapid-acting insulins and regular insulin. If you see that onset of action is, even though it is rapid-acting, it is 15 to 30 minutes. And for regular, it is half an hour to 1 hour. And now we have a newer insulin available approved for children more than 1 year, which is Fias from Novo Nordisk. Even though this is named as ultra fast acting, still it takes about 10 to 20 minutes to initiate the action. So when you compare it with endogenous insulin secretion post meal, these are absolutely not comparable. Like the endogenous insulin production is instantaneous when compared to even the ultra fast acting insulin. So what are the implications of understanding this onset of action? So basically, when you are giving your pre-meal insulin, this is your blood glucose rise. I'm sorry, this is and this is so you give both insulin and food at the same time. The food releases blood glucose so quickly, so that your blood sugar is high even when insulin is not ready in the system. When the insulin is at its peak, your sugar is already dropping. So what happens here is that you will get an early hyperglycemia followed by hypoglycemia unless you're kind of overlapping these two graphs. So how do you do that? So basically, when you give your insulin a little bit earlier and wait for half an hour to 1 hour based on the type of insulin you are giving. So wait for 20 minutes for rapid acting, at least half an hour to 40 minutes for regular. So then you will achieve a better post-meal glycemic control. This is the funda of learning the onset of action and using the pre-meal insulin appropriately and waiting before eating. And before going on to the insulin regimes, a little bit about the available long-acting insulins. So we have glargine, known as Lantus. So usually given once a day. Sometimes we do give twice a day. So traditionally, we do give it at bedtime, though we can give it any point of time. And another long-acting insulin available, analog insulin, is Deptemir, available as Levemir. It is used twice a day. We do use this in the place of Lantus in very young children. This action profile is sometimes a bit similar to NPH, but with very less risk of hypoglycemia when compared to NPH. So it can cover for in children under 1 to 2 years where they have multiple multiple episodes of breastfeeding. To cover for all those tiny boluses of meals, we do sometimes give Detamir 2 injections a day. And the other long-acting is Degludec or Tresiba, which is especially useful for older children and preteens and teens. And NPH, again, very commonly used insulin. Sometimes we do use NPH alone as basal insulin. Sometimes we do use NPH in combination with Lantus as basal insulin. But we need to give twice daily. Remember the peak we are talking about, the peak of the insulin. So NPH has a potential to cause hypoglycemia at the time of the peak. So we need to remember to make sure that the child has mid-morning and bedtime snack whenever we are using NPH as the basal insulin. So coming to insulin regimes, what are the types of insulin regimes that we use in type 1 diabetes children? The standard of care, and I think every single pediatric endocrinologist would agree with me that the standard of care should be a basal bolus regime. A basal bolus regime is not decided based on the financial status of the family, not decided based on the literacy of the family, but we can do the basal bolus regime even with low cost insulins, even in family with literacy. So the common variety is using either pre-meal boluses. MDI means multiple daily injections. CSSA means continuous subcutaneous insulin infusion in the form of insulin pump. So what are the common variations of basal bolus? This is the typical basal bolus regime that we do follow for every single child that we discharge after DKA, though we don't give this bedtime snack bolus. So we do give a basal insulin with either Lantus or Basalog. For basal the glargine, we have biosimilar glargine available in India with the name of Basalog, which is much cheaper than Lantus. So in families who cannot afford Lantus, we can go for Basal using Basalog, which is available both as vial as well as pen. So, and we do use 3 to 4 pre-meal boluses. Many of our kids do need a pre-snack meal bolus also, because many children do have a big carbohydrate snack like idli or dosha, which they cannot eat without taking a pre-meal bolus. So 4 to 5 injections a day is a standard of care for every single child under our care, and unless in very exceptional situations where the family scenario dictates otherwise. So this is another modification. This also we tend to use 2 injections, 3 places to cover the next hole, and largely at night instead of NPH at night, so that I can avoid this peak. You see this peak happening between 2 to 3 a.m. So any child on this particular basal bolus needs to have a bedtime snack. If the child is having midnight hypos, maybe you can consider removing this NPH at bedtime and replacing it with glargine of the same dose you can use, which can be modified later. I think this is the commonest regime many of you might be using, split mix regime using NPH and regular. Here we do use a similar kind of basal bolus, but without lunch bolus. To decrease the number of injections, the regular and NPH can be mixed in the same syringe, but you need to draw the regular first followed by NPH. We sometimes use it, but you can simply make this also into basal bolus by just adding another bolus. How if we have a family who are completely against taking school lunch bolus, pre-lunch bolus at school, just to make it, from day one onwards, we stress the importance of pre-lunch bolus. Most of our parents come with certain kind of an arrangement to give insulin before lunch at any cost. But if you come across with a a patient or a parent who is very reluctant to do a pre-lunch bolus at school, you can ask them to have a very, very, very low carb lunch for school, and they come home and have a proper lunch at 4 o'clock after taking the regular. So here also we do give multiple injections, but we don't give lunch, proper lunch. They come home, take regular acting insulin, and then eat a big lunch followed by another dinner with a pre-dinner bolus. So it's a modification of basal bolus to if there is no means to give insulin at school. Premixed insulins, as a principle, should not be recommended in pediatric use unless in extreme scenarios, like the family situation is very bad and you just want the child to survive and take at least some insulin every day, and there is no other option other than premix. Then only we would be giving any sort of premixed insulin prescription, because in premixed insulin your regular and your NPH, the basal, are already mixed. So if you want to change regular, you'll end up changing NPH also. There will be a lot of ups and downs. There's a lot of seesawing that is happening with adjustments of doses with premixed insulin. So it is not the ideal of ideal care. So it's only used in bad compliance, very limited access to diabetes care, where you just want the child to take some insulin. Even then, we would try to push for a split mix, if possible, with the injections and basal bolus. Why not just stick to 2 injections a day? For a very good reason. So look at this endogenous insulin secretion. So you can zero on the top list, depends on the number of times you eat. So if you want to take care of a type 1 diabetes child and give them a long and full life without any complications, you'd like to think like pancreas and act like pancreas. So if your pancreas is acting like this, then of course we need to act like this to get a good glycemic control. So type 1 diabetes treatment goals have changed a lot in 1922 when the insulin was discovered, from controlling blood glucose to keep the person alive to maintaining a good quality life and prevent long-term complications. There's a very interesting study that came in 1960 based on this data. Basically, what happened when the insulin was diagnosed, there was only regular insulin. So because it works only for 6 to 8 hours, it was given 4 times a day. before each meal and at midnight. In 1935, what happened was lenti insulin was discovered, the long-acting, intermediate acting. So the physicians thought, when we have a long-acting, why to give so many injections? Then switch to 2 injections a day or 1 injection. And what happened? And when the people who were diagnosed before 1935 and receiving 4 injections a day fared much, much better in terms of long-term retinopathy risk. A whopping 61% had retinopathy in 2 injections group versus only 9% in the 4 injections group. This is a very, very clear-cut indication that basal bolus is needed. And this landmark that intensive insulin therapy using dose adjustments dynamically with education and multiple injections, it decreases the long-term complications. In the intensive regime, we maintained the A1C at about 7% versus conventional 2 injections a day regime had an A1C of 8.5 to 9%. And if you see that there is all the complications like retinopathy, nephropathy, and neuropathy, the risk reduction was quite significant in intensive therapy group on a long-term basis. So that is the logic behind using basal bolus therapy as the standard of care. The ISPAD, International Society for Pediatric and Adolescent Diabetes, recommends basal bolus therapy as a standard of care for any child or an adult with type 1 diabetes. So when you decide to shift to subcutaneous, what are you going to do now? So you have decided your type of insulin, so either rapid or short acting. This is the dose initially, the first dose, 0.2 unit per kilo. Stop IV insulin 30 minutes after rapid acting or 40 to 60 minutes after the short acting. So if you're using Actrapid, stop IV after 40 minutes. If you're using like Novorapid, Humalog, stop after 30 minutes to prevent rebound hypoglycemia. And when to give the basal insulin now? So basal can be started along with your regular when you are changing subcutaneous, actually a little bit before itself. The starting dose of basal is 0.3 to 0.4, whether it is glargine or NPH. So if it is NPH, we will calculate to 0.4 and is actually, the starting dose is only 0.3 to 0.4. Few hours before stopping IV. So if you're planning to shift to subcut in the morning before breakfast, you can actually give the basal analog the night before. If you're using NPH, you can use it like 2 to 3 hours before. So plan ahead. If you know that the child is improving, you know that you're going to shift to subcut insulin, then you plan ahead and start basal even before you stop the IV insulin. So these are the 4 cornerstones of good glycemic control in the long run. Insulin is just one part of all these 4. Today, I don't think we can cover all these. I'm going to concentrate only on how insulin management and a little bit about blood glucose checking in the next few slides. The healthy eating and physical activity have to wait for another session. So when you are after giving your stat dose of your regular or rapid acting and basal insulin, then you sit down and calculate your total daily dose. So what is the total daily dose for pre-pubertal children? Anywhere between 0.7 to 1. And it is just a starting dose. It can go up to 2 units in pubertal age group. After discharge, it can go down to 0.5 also in the honeymoon phase. So how to divide? So you have calculated the total dose, how to adjust basal versus bolus. So basal, this is for basal bolus regime. So if you're using basal bolus regime, even with NPH and regular, if you're using NPH, the calculations are different. I'll tell them later. If you're using basal bolus using glargine or detimer, these are the calculations. So 30 to 40%. Yes, basal if you are using regular insulin, because regular insulin Actrapid has a longer duration, 6 to 8 hours. So it has a little bit of basal action. So you don't need much basal if you are using Actrapid. So you will use 30 to 40%. If you are using rapid acting, you can use up to 50% as basal insulin. The remaining amount of insulin divide into pre-meal boluses. So if we are achieving, this is what we typically use in all our children. We usually do the glucose adjusted insulin regime in very well motivated and parents who can understand things very quickly. We try to do the meal adjusted regime also. But glucose adjusted regime is universal in every single child that we see after DK. So what is it? Basically, we do dynamic adjustments of insulin dose before every meal based on blood glucose, if possible, meal carbs and activity. So based on blood glucose, we have to do on every child, and if possible, meal carb adjustment also we have to do. So the purpose of bolus that you give before meal is to bring down whatever existing high glucose into target level, and also cover for the meals that the child is going to eat. Just for example, before breakfast, a child has a blood glucose of 70 versus 350. So how does it make sense to give the same amount of insulin even for 70 and even for 350? No, right? So for 350, you would like to give a little higher dose of insulin. So which should be the adjustment that you make for the blood glucose. And at this point, it's important to understand the concept of correction factor and how to calculate it. What is correction factor or correction bolus? So correction factor is the drop of blood glucose for each unit of insulin. So if you give 1 unit of insulin, how much blood glucose drops because of that particular 1 unit of insulin? That is correction factor. It's a simple calculation, 1700 by total daily dose. The total daily dose is all the amount of insulin that you have given the previous day, including long-acting, short-acting, and all insulin. So coming to a simple example, so you have a new patient, you already changed to subcut by giving that 0.1 unit of regular, 0.3 unit of basal. Now you're sitting down with your calculations. You want to give 1 unit per kilo. You decided on basal bolus. So your total daily dose, 20 kilo into 1, 20 units. And you want to give 40% as basal. So 40% of 20 is your 8 units. So your 8 units is basal. So the remaining 12 units is your boluses. So you divide that into 3 or 4 pre-meal boluses. And what is your correction factor? 1700 by total daily dose. So your total daily dose is 20. So this is approximately 85. It means that 1 unit of insulin drops the sugar by 85 milligram per deciliter. How to divide the pre-meal boluses of the 12? Of the 12, you need to divide for breakfast, lunch, dinner, maybe evening snack. So look at what time child is eating more, what time child is eating less. The child is eating more breakfast and lunch, you would give little more of this 12 at breakfast and lunch, give little less for snack and dinner. So look at the typical prescription, assuming child is eating same amount of carbohydrates every meal. So this is what I'm going to write. In a child with basal bolus, I decided to give lantus or basal at bedtime, 8 units. We have calculated that. My correction factor, I rounded it off just to make it easy for me. 85, I just made it 80. And bolus rapid acting insulin, I decided to give either Novorapid or Humalog. Remind you, we need to give it 20 minutes before meal. That has to be given in the instructions. And between 70 to 40, that is my goal. My goal blood glucose is 70 to 140. So between 70 to 140, I divided the 12 units of Novorapid like this: 3 for breakfast, 4 for lunch, 2 for evening snack, 3 for dinner. Beyond 140, for every 80 mg per deciliter, I kept on adding 1 unit. This is the correction factor that I'm adding. So 1 unit of correction for every 80 extra blood glucose over 1. So that's the usual prescription that we follow even in inpatient and outpatient basis. Here you can see that I have a row for less than 70 also. See, less than 70 means hypoglycemia. You have a child in the ward, at lunchtime you have checked the sugar and that is 65, whether to give the pre-lunch bolus or not. You have to give the pre-lunch bolus after correcting the hypoglycemia. So you cannot skip insulin even if the child had hypoglycemia. First, though, you correct the hypoglycemia by giving sugar, make sure the blood glucose has risen, and give the pre-lunch bolus, but maybe a little bit lesser than usual. So 1 unit less. And maybe you don't have to wait 20 minutes because the child just had hypo. So give insulin, maybe immediately give the food. Never skip insulin if the child is having a big meal. And in the inpatient management, when you're doing basal bolus, additional correction doses may be needed even beyond the time frame when we give the prescription. For example, if you face a high blood glucose at bedtime, or at 3 a.m., we don't have bedtime at 3 a.m. Just more than 200 to 50, you cut it down to 150 to 200. Here we know the correction factor, which is 80. So 250, if you want to correct it down to 150, it will be 100. So approximately you need 1 unit to bring down the blood sugar. So you will be giving just 1 unit of Actrapid or rapid acting at 3 a.m. If you see a blood glucose of 250 at 3 a.m. So you cannot ignore that in the inpatient management. That cuts short the duration of hospital admission by bringing down the sugars very quickly so that you can discharge the patient earlier. If you're using fixed insulin dose regimes, you adjust the dose based on the blood glucose pattern over a day for few days, watching it over a day for few days. So how to do if you're using split mix regime? 2/3 of the total daily dose is used as NPH, of which another 2/3 is used as in the morning time and 1/3 is used in the evening time. The remaining 1/3 of the total daily dose is used as regular or rapid acting, divided into pre-meal boluses. So if you are using split mix only 2 doses, you divide it into 2 pre-meal boluses. If it is 3 doses, divide into 3 pre-meal boluses. Here, if you can see, the basal is very high. 70% is basal. If you are using NPH, almost like 66%. So if a split mix regime pre-lunch bolus, how you're going to decide? 12-year-old boy with 36 kilo. Your total daily dose is 36 units, of which 2/3, which is 24, is your NPH. And then remaining 12 is your regular. That you're going to divide as pre-meal doses, which can be adjusted with blood glucose levels. And your morning NPH is 2/3 of 24, which is 16. So the remaining is your evening or bedtime NPH, which is 8 units. So this is the typical prescription for NPH and regular based regime. Here, regular, whenever you're using pre-meal bolus, you can little bit adjust for the blood glucose. But not really in a good way, because NPH kind of exerts some activity beyond 10 hours. So once on day 1, you have shifted and you charted your insulin with total daily dose and check blood glucose every 3 hours, pre-meal, pre-snack, bedtime, and 2 to 3 a.m. So breakfast, lunch, dinner, 3 times, 4, 5, 6, total 6 times you're going to check your blood glucose and give your boluses and calculate correction factor, give correction dose as needed. And on day 2, what you're going to do? When come to the morning rounds, calculate the total daily dose that was given on the previous day and redo the insulin charting. How? So you have charted 20 units, but you ended up giving 27 units because the sugars were high. So you have given this units, total 27. So for 27 units, now you're going to take it as total daily dose. That you're going to divide again 40% basal, which becomes 11 instead of previous day's 8. And then remaining is bolus, which is 16 instead of previous day's 12. So every day you're going to redo your calculations based on the previous day's total daily dose, assuming there are not many hypoglycemias previously. So if you are using split mix 2 injections a day regime, you cannot do daily adjustments. Then you calculate total daily dose of the previous day and you look at the blood glucose levels. If you're using split mix regime, you look at glucose levels with the blood glucose higher than increase or decrease based. It's time to discuss parents how to give the injections, check the blood glucose. You calculate total daily dose. Based on that, you divide and give a chart to the patient. Most sugars are less than every life. So do not discharge without touching management of hypoglycemia, and a prescription for a glucagon injection most of the times freely available for 500 rupees or 600 rupees, which needs to be used in case of severe hypoglycemia, and ketoacidosis, which just cost about 300 rupees for urine ketone checking whenever the blood glucose is persistently more than 300. These two are very, very, very important. And insulin administration storage guidelines have to be explained, site rotation has to be explained, and least be briefed, if not explained in detail, not to skip the insulin during sick days. And what's the importance of self-monitoring? This is a chart is the costliest aspect of type 1 diabetes management. So if money is an issue, so we're going to give at least check at least 2 to 3 days a week for at least 4 times in a day. And then look at the records every week and adjust the doses accordingly. So because the management of type 1 diabetes is like a tightrope walk, controlling highs and lows. Imagine doing it blindfolded. So that is how it feels if you're not checking blood glucose and trying to manage type 1 diabetes. Blood glucose checking has equal importance as equal as giving insulin. So these are the target values of ISPAT 2018 guidelines, pretty stringent. Pre-meal 70 to 130, almost normal. Post-meal never more than 180. So basically 70 to 180 is the goal. Target A1C is less than 7%, which is very difficult to achieve. We try to keep it at least 7.5%. And very quickly, I'll go through ongoing adjustments in the next 2 to 3 minutes. Initially, we do the adjustments, and later on, we'll try to teach the parents. So we need to remember that blood glucose depends on these three: insulin, meals, activity. So if we try to adjust the insulin and teach meals adjustment and activity adjustments also to the parents. So remember the action of the insulin. Remember which insulin affects which glucose, so that you can adjust that particular insulin. Bedtime lantus affects the before breakfast sugar levels. Breakfast insulin affects before lunch sugar. Lunch insulin affects before evening snack or even before dinner sugar. Evening snack insulin after dinner insulin affects dinner sugar. That's how you know that the which sugar is going to which insulin affects the which sugar. So if lunch sugars are going up and down, you're going to adjust your breakfast insulin. So look at patterns over a course of 1 or 2 weeks, patterns of low, patterns of high. There's a 3-day rule. Any 3 days in a week consecutively or any 3 days upper, higher, low, then you're trying to adjust the particular insulin. Always adjust low sugars first. And if more than one sugar is out of range, adjust the ones that happen earliest in the morning, earliest in the day. The morning sugars, adjust the morning sugars first. Wait for 2 to 3 days before making another change. So if morning sugars are high, for example, consistently for 3 days, then you're going to adjust the bedtime lantus. So you're going to increase the bedtime lantus and then wait for 3 days before making another change. So how much to increase based on the total daily dose. So if you this is the average daily dose for many kids. So we go by 1 unit increment or decrement. For older children, 2 units increment for decrement. So I'll skip this. So basically, whatever might be the insulin regime, it has to be supported by comprehensive education and regular review and reassessment. The correction doses also change every few months because the total daily dose changes. So it has to be redone. The prescription keeps on changing, and preferably parents adjust the doses at home on a weekly basis, if not daily. So before I wind up, I just want to give a teaser. We are having a pediatric diabetes update in November 21st and 22nd. We are having live online. It's a web-based session with national and international faculty, aiming for pediatricians, physicians who are interested in caring for type 1 diabetes, educators, nurses, and dietitians. We're going to, the registrations will be open pretty soon after the agenda is finalized. So if anybody has any doubts, you can just reach me at this email ID. Thank you.
Yeah, thank you, Dr. Sirisha. It was a very informative talk on how to manage diabetes and after DKA and OB basis. Now we'll see any questions are there. Yeah, one question for Sirisha. We are using mixed for most of the child in our OP basis. Now, with your talk, it is said that mixed should not be used or should be used only in certain circumstances. What to do?
Yeah, we need to change it's like changing practice needs a lot of that's the job. My job here of explaining this importance of multiple daily injections. We need to change the practice with medicine changes every single day, every single minute. We used to give 20, 30 years back, mixed start was a standard of care even in type 1 diabetes. But for all these very clear-cut reasons, it is not the standard of
But are we
anymore. We have
justified
to
in?
change our practice according to the evolution of the science. So if you want, yeah, yes, Ramsey.
That are we justified in giving so many
Hello.
injections? Are we justified in giving so many injections to children? That's the next question.
Absolutely, that's the most important. Here, the number of injections, the day-to-day management you're looking at. What I am looking at as a carer, as a primary physician, is 40 years, 50 years down the line. Will I be able to give a normal life to this child, where the child is not going in and out of hospitals after 20 years, where the child is not requiring a renal transplant, where the child is not losing his or her vision after 20 years, where the child will be able to grow up and have a job and have kids and have a normal life. That is what is the goal as a pediatric endocrinologist to me. For that goal, we have to go through this inconvenience or the seeming cruelty of multiple daily injections and multiple daily blood sugar check. Is not the injection. Every single child in any of our pediatric endocrinologist care will have minimum 4 finger pricks, minimum 4 injections. And if you tell them on day 1, kids are absolutely okay with it. Parents take some time to get used to it. They take 3 to 6 months, but kids are like, they just get used to it in 2 weeks. So the goal is a long-term, normal, fulfilled life rather than tiding over this particular day or tomorrow or just tomorrow.
Hema, for DKA in the first hour, what you are using, either NS or RL, what you are using at your center?
Till now, guidelines also recommend usage of normal saline in the initial phase of fluid resuscitation. As I mentioned, one study which compared normal saline with plasma-lite, that is balanced electrolytes, they didn't show any big difference between the two groups in the mean time to resolution of DKA or mean time to reduce the glucose levels be less than 250 mg per deciliter. Till now, that is initial fluid of choice is NS. So once into 4 to after 4 to 6 hours into resuscitation, I think ideally we should switch to half NS or half DNS.
Yeah, no more questions. Now I thank the almost 120 attendees were there for the session. Those small hiccups were when Sirisha was, I think there is some net problem with you, Sirisha, at yours and this one, but overall it was a good presentation. So thank you very much for this one, and thank you, Dr. Sirisha, for giving your experience talk on both DKA and follow-up of diabetes patients. Now, thank you all. I'm winding up. Now, I think there are no more questions here. Thank you, one and all. Thank you.
Thank you, sir.
Thank you, Dr. Ramsad. Thank you.